Hi, I'm here at ASH 2017 in Atlanta, Georgia. I'm going to discuss a few topics in acute myeloid leukemia, especially in the older population. And I'm going to divide my comments into older patients who are fit for chemotherapy and those who are not. And we're going to start with those who are fit for chemotherapy. I think one of the biggest developments in 2017 has been the FDA approval of the liposomal formulation of daunorubicin and cytarabine. This liposomal formulation is a perfect 1:5 molar ratio of those two drugs, which in vitro and in animal models has shown synergy. So the liposomal formulation allows you to deliver that 1:5 molar ratio more consistently, and the liposome appears to target the bone marrow more than other tissues, at least in animal models, and it appears that the leukemic blasts more selectively take up the liposomal formulation than normal blasts. And so based on a large phase 3 study, CPX 351, that's what the investigators called it, liposomal daunorubicin cytarabine was approved for previously untreated adult patients with acute myeloid leukemia that was either treatment-related or with myelodysplasia-related changes. It was based on a phase 3 study of patients between the ages of 60 and 75 with either treatment-related AML, AML with myelodysplasia-related changes such as secondary AML due to an antecedent hematologic disorder, whether they got hypomethylating agents or not, or de novo AMLs that had myelodysplasia-related cytogenetic changes. In that population, there were about 150 patients randomized to the two arms. The benefit of CPX 351 or liposomal daunorubicin cytarabine was shown in an improvement in survival that was statistically significant and met the primary endpoint of the study. And so the median survival of patients who received CPX 351 was about 9.5 months, and that of those who received 3+7, the standard induction treatment, the median survival was about 6 months. There was also an improvement in CR rate. There was also an improvement in the number of patients who went on to allogeneic transplant. And by landmark analysis, those patients who went on to transplant following CPX 351 had a better survival than those who went on to transplant following the standard 7+3 followed by 5+2 consolidation. And this wasn't at the cost of increased induction mortality. In fact, the 30-day and 60-day mortality were lower in the CPX 351 group than in the standard 7+3. The excess mortality apparently being due to persistent disease in the patients receiving 7 and 3, with similar mortality due to the toxicities of the agents. And so CPX 351 truly is a chemotherapeutic agent. It should be used in patients who are fit for chemotherapy, but in that population of older patients who typically have poor risk features, this does appear to be a step forward. More needs to be done, obviously, to add on to this, but we're very encouraged by this first step. Now, turning our attention to patients who are deemed less fit for chemotherapy, and of course that's a subject in and of itself, how an investigator decides if a patient can tolerate intensive therapy or not. There are a number of models that have been devised. My criticism of all these models that make them of limited utility to the practicing physician is all of those models are built on patients who have received intensive chemotherapy. And so there's already been an incredible selection done by the investigator and the patient. So it doesn't really allow you to determine which patients walking into your clinic would be most suitable for intensive therapy or not. But having assumed that we do see these patients, since only about 40% of Medicare recipients in the United States actually receive therapy, they clearly exist. What are the options? And typically what we've been using are the hypomethylating agents, azacitidine or decitabine, and some use low-dose cytarabine. Those are the three agents. Now recently, this summer, another agent was approved exactly for this group of patients, and that's gemtuzumab ozogamicin, the anti-CD33 antibody drug conjugate. This was based on a phase 3 study done in Italy for patients who were deemed unfit for any therapy, and they were randomized between gemtuzumab at 6 milligrams per meter squared and then 3 milligrams per meter squared with a maintenance after that versus just best supportive care, and there was an improvement in the survival of those patients, and that added to the data supporting the label that was granted by the US FDA this year for gemtuzumab ozogamicin. I'll just finish with what a lot of us are excited about, and that is the activity of the BCL2 inhibitor, venetoclax, in older patients with acute myeloid leukemia. At this Congress and at previous meetings, we've heard a lot of data about combining venetoclax with hypomethylating agents or low-dose cytarabine, and we're going to hear updates of those studies. Just today, Dan Pollier presented data from a study of venetoclax with azacitidine and looked at the patients he was putting on at his institution. And he made some interesting observations, including the ability to drive the disease into a negative state for minimal residual disease using a very sensitive PCR applet assay, droplet PCR. The other thing that was quite impressive about that presentation is that there were 2 patients who not only achieved an MRD negative state by this droplet PCR technology, but also, even though they came off treatment, they're in long-standing remission for months or a year or so afterwards. So I think we need to hear more about that. He presented some hypotheses about why this combination might particularly be effective, especially at getting to the leukemic stem cell. So people looking at this might want to look at that abstract. So after 40 years of trying to push beyond 7 and 3, I think we're finally seeing some real activity and breakthrough that are going to benefit our patients, especially the older ones with acute myeloid leukemia.